Welcome to this Step 3 review on intensive care admission and management. This video is brought to you by Roadmap to Residency. Critical care questions feel intimidating, but they follow predictable patterns, and once you know the patterns, they become some of the most answerable questions on the exam. Our goal today is not to reteach all of critical care. It is to show you how the question stems are built and how to attack them quickly and correctly. We will cover how to decide who belongs in the intensive care unit, how to sequence initial stabilization, how to handle sedation and pain control, and how to remember the routine prevention of clots and stomach bleeding. We will work through board-style practice questions together and explain why each answer is right or wrong. Make sure you are also drilling your question bank and a solid critical care review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is what we are going to cover today. First, we will learn to recognize when a patient belongs in the intensive care unit and how the exam signals it through unstable numbers. Second, we will sequence the initial stabilization of a crashing patient, then handle sedation and pain control, and finally lock in the routine prevention of clots and stress-related stomach bleeding. Along the way, we will walk through several board-style practice questions together and explain exactly why each answer choice is right or wrong. This video assumes you have baseline knowledge from your critical care review resource. We are here to sharpen how you take the test. Our first strategy is to decide who actually needs the intensive care unit. The exam signals this through unstable numbers, so train your eye to spot them. Look for blood pressure that stays low even after fluids, a breathing rate that is climbing or failing, low oxygen levels, an altered or confused mental status, and a rising lactate. When the STEM stacks several of these abnormal vital signs together, the patient needs closer monitoring than a regular ward can provide. The second half of this strategy is to count the failing organs and ask what intervention the patient needs. A patient who requires a breathing machine, drugs to support blood pressure, or continuous kidney support belongs in the unit. The single clearest trigger for admission on a board question is the need for an intervention that can only be delivered with close nursing and continuous monitoring. When you see that, the level of care is the answer they are after. Strategy 2 is to stabilize the patient in the right order, and this fixed sequence answers a surprising number of questions. When a patient is crashing, you secure the airway first, then support breathing and oxygen, then restore the circulation with fluids and, if needed, drugs that raise blood pressure. Airway, breathing, circulation, in that order, every time. If the STEM describes a patient who cannot protect their own airway or is barely breathing, the answer is to manage the airway before you order any scan or laboratory test. The second half of this strategy is to treat first and diagnose second. In an unstable patient, a stabilizing action beats more testing. Give fluids to the patient who is dry and in shock before sending them to advanced imaging, and start broad antibiotics quickly when infection is suspected. Be suspicious of any answer choice that sends an unstable patient to a scan or a procedure before basic resuscitation has been done. The treatment that protects life right now is the next best step. Strategy 3 brings together sedation, pain control, and routine prophylaxis, which the exam tests constantly. First, treat pain before you add sedation. A great deal of the agitation in a ventilated patient comes from untreated pain, so control the pain with an analgesic first, then add light sedation only as needed. The exam rewards a calm, awake, and comfortable patient over a deeply sedated one, so favor the answer that targets the lightest effective level. Second, prevent clots and stomach bleeding. Nearly every intensive care patient needs 2 routine preventions. Give a blood-thinning injection to prevent leg and lung clots unless the patient is actively bleeding. And in that case, use a compression device on the legs instead. Give acid-suppressing medicine to prevent stress-related stomach bleeding in patients on a ventilator or with a clotting problem. Third, remember the daily checklist. Lighten sedation each day and check whether the patient can breathe on their own. Raise the head of the bed to prevent pneumonia, prevent clots, protect the stomach, and review every line and catheter for removal. When a STEM asks what is missing from the plan, the answer is usually the prophylaxis step that was skipped. Let us work through our first practice question, and this one tests whether you can decide who needs the intensive care unit. A 68-year-old man is admitted with pneumonia. Over a few hours, his blood pressure falls to 80/40 despite 2 liters of intravenous fluid. His heart rate is 120, his breathing is labored at 32 breaths per minute, and his oxygen saturation is only 88% on a face mask. He is confused and his lactate is rising. The question asks for the most appropriate next step. Notice how the stem stacks the danger signs together and watch the trend across those few hours. Read the 4 options carefully and pick your answer. Then we will walk through the reasoning together on the next slide. Let us break this down step by step. First, spot the pattern. The stem stacks the danger signs on purpose. The blood pressure stays low after fluids. The breathing is fast and the oxygen is poor. The patient is confused and the lactate is climbing. This is shock from infection with more than one organ system failing at once. Second, apply the rule. A patient who needs drugs to raise blood pressure and close support for failing breathing can only be managed in the intensive care unit, so transfer to the unit for vasopressor and respiratory support is the answer. The need for an intervention that a regular ward cannot deliver is the trigger for admission. Third, eliminate the wrong answers. Continuing the same care simply wastes time while the patient deteriorates. Ordering a chest scan delays resuscitation and pulls an unstable patient out of a monitored setting. A general medical ward bed cannot provide blood pressure drugs or close respiratory support, so that is a move to a lower level of care. Each wrong choice either does nothing or sends the patient the wrong direction. The correct answer is transfer to the intensive care unit. Here is our second practice question, and this one is all about sedation and pain control. A 70-year-old man is on a ventilator in the intensive care unit after surgery. He becomes agitated and starts pulling at his lines. His heart rate is 110 and his face is grimacing. Importantly, his blood pressure and oxygen levels are stable, and he has not received any pain medicine since he arrived from the operating room. The question asks for the most appropriate next step. The key detail here is that this fresh post-surgical patient has had no pain control at all. Think about what is driving the agitation before you choose. Pick your answer, and we will reason through every option on the next slide. Let us work through this answer. First, find the untreated pain. The stem hands you the clue directly. This patient has had no pain medicine since major surgery, and he is grimacing with a fast heart rate. Agitation in a fresh post-surgical patient is most often untreated pain, and the test writer wants you to treat the cause rather than simply blunt the patient with sedation. Now, why does the gentlest step win? Giving an analgesic to control the pain first is the answer. A deep, continuous sedative infusion masks the pain without treating it and leaves the patient overly sedated, which is exactly what modern critical care tries to avoid. Applying restraints addresses the behavior but ignores the cause. Giving a paralyzing agent to an awake patient who is in pain is dangerous and clearly wrong. The rule is to treat pain first, then add only light sedation if it is still needed. The correct answer is to administer an analgesic to control pain first. Let us talk about how to work the intensive care stems themselves, because the way these questions are written gives you the answer if you know what to look for. First, read the trend, not the snapshot. Critical care stems give you numbers over time on purpose. A single blood pressure reading matters far less than the direction it is moving. When the stem shows the blood pressure falling, the breathing rate climbing, or the urine output dropping across the hours, the patient is getting worse, and the answer is to escalate care. Always track the trend before you commit. Second, stabilize before you investigate. When a patient is unstable, the correct next step is almost always a treatment, not a test. If 2 choices both look right, one giving a fluid bolus or oxygen, and the other ordering a scan, the stabilizing action wins. Save the diagnostic workup for the patient whose vital signs are already under control. Treat the patient in front of you first, and the rest of the question falls into place. Here is our third practice question, and it tests the routine prophylaxis checklist. A 55-year-old woman is admitted to the intensive care unit with respiratory failure and placed on a ventilator. She is sedated and receiving antibiotics, intravenous fluids, and acid-suppressing medicine. Importantly, she has no active bleeding and her clotting studies are normal. On review of her orders, the team notices that one routine preventive measure is missing. The question asks for the most appropriate next step. The trick here is to mentally run through the daily prevention checklist and figure out which step has not been ordered. Choose your answer, and we will reason through every option on the next slide. Let us break down this answer. First, spot the prophylaxis gap. The stem tells you she already has acid suppression protecting her stomach, along with antibiotics and fluids. The routine prevention that is missing is protection against leg and lung clots. An immobile, sedated patient on a ventilator is at high risk for clots, and the STEM specifically tells you she has no active bleeding to stop you. So starting a blood-thinning injection to prevent clots is the answer. Now, the key distinction between the wrong choices. Adding a second acid-suppressing medicine is needless because she is already protected against stomach bleeding. Beginning an insulin infusion treats a problem the STEM never describes. Ordering daily routine chest radiographs is not a preventive measure, and reflex daily films are no longer recommended. Each distractor either repeats a step already done or adds something that is not indicated. The correct answer is to start a blood-thinning injection to prevent clots. Here is a critical example that ties all of our critical care strategy together, and it is the stability first rule for every intensive care STEM. Before anything else, ask one question. Is this patient stable? Scan the vital signs and the mental status on your very first read. If the patient is unstable, your answer must be an action that supports the airway, the breathing, or the circulation, and you can usually eliminate any choice that orders a test instead. If the patient is stable, you have room to slow down and work through the diagnosis in an orderly way. Then ask the second question. What is the single biggest threat to this patient right now? And treat that first. Resist the pull of the impressive but premature answer, such as an advanced scan or a specialist procedure, when a simpler stabilizing step is sitting on the list. The choice that protects life in the next few minutes is almost always the correct next step. Stability first, then the biggest threat. Make that your reflex on every critical care question. That wraps up our review of intensive care admission and management for Step 3. Remember the core ideas we covered today. Decide who needs the unit by spotting unstable vital signs and the need for an intervention a regular ward cannot deliver. Stabilize in the order of airway, breathing, and circulation, and treat the unstable patient before you investigate. Treat pain before you reach for sedation. And never forget the routine prevention of clots and stress-related stomach bleeding. And on every critical care STEM, ask first whether the patient is stable, then treat the single biggest threat to life. The best way to lock all of this in is to drill questions in your bank and read every explanation, even on the ones you got right, while keeping a trusted critical care review resource close by. Visit roadmaptoresidency.com for expert tutors and residency advisors who can help you build a personalized study plan. If you found this video helpful, please like and subscribe so you do not miss our next board review session. Good luck on your exam, and we will see you in the next video.